All right. We're going to go ahead and start this presentation. I appreciate everyone for joining. This is going to be an inside look at drug testing pre and during COVID-19. We are joined today with Dr. Joseph Stanton, the Associate Director of Clinical Affairs with Millennium Health. Dr. Stanton has over a decade of clinical research experience in chromatography, mass spectrometry, toxicology, and pharmacogenetics. At Millennium Health, Dr. Stanton collaborates with various departments, including education, sales, marketing, and R&D, aimed at improving clinical outcomes for people suffering with pain, addiction, and other mental health disorders. Dr. Stanton joined Millennium Health in 2014, and since then has educated thousands of clinicians across the country on the importance of laboratory clinical interpretation to improve patient outcomes. Prior to joining Millennium Health, Dr. Stanton completed his doctoral research at the University of Maryland School of Pharmacy and School of Medicine. We're also joined by Dr. Eric Dawson, who is the Vice President of Clinical Affairs at Millennium Health. Dr. Dawson is keenly aware of the issues of drug abuse, misuse, and diversion. Dr. Dawson is passionate about educating clinicians on the topic and has given many lectures to pharmacists, nurses, and physicians. Dr. Dawson has also authored or co-authored a number of publications on drug abuse, utilizing the outcomes of his own research. Dr. Dawson earned his Doctor of Pharmacy degree from Auburn University, graduating with highest honors. He is also a licensed pharmacist in the state of Alabama. So with that note, welcome Dr. Stanton and Dr. Dawson. Thank you so much.
All right. Well, thank you, Nestor, and hello, everyone, and good afternoon. I just wanted to say thank you all for joining us this afternoon, and thank you to Kipu for inviting us to speak, and I hope you all enjoy the program. As Nestor said, my name is Joe Stanton, and I'll be joined by my colleague, Dr. Eric Dawson, down in Alabama. And needless to say, 2020 has been an interesting year, to say the least. And it's remarkable how COVID-19 has not only affected all of our lives, but how it's affected drug trade and drug utilization trends globally and here domestically as well. And as you can see from the title, the analysis I'm going to be sharing with you is part of a yearly report produced by our clinical affairs team at Millennium Health called the Signals Report. And how fitting that the title is The COVID Connection, as we tracked the 2020 trends in drug use from urine drug test results in patients seeking healthcare. And these have become urine drug test analysis. This certainly become a new resource that's being utilized in parallel with some of the more traditional resources used to track emerging drug trends. And we're certainly proud of this work, and I believe it's one of the first of its kind, some of the earliest data that you will see in regards to drug use during COVID-19, and there should be more to come, but we're very proud to be able to put something out so quickly. And Eric, I maybe you would want to add into just how near real time this data can be before we get started.
No, I think, yeah, everyone will see that in the report, and I'll even make a few comments as it relates to what even more current information that we have is. For those that don't know, we have an agreement with the U.S. Department of Health and Human Services. As part of that data sharing agreement that we have with them, we do provide a report every 2 weeks. And so I have actually data through, I guess, about the first week of March or so at this point, literally, wow, a week or so ago. So while Joe will present results through the end of December 2020, I may interject in a couple of places and bring us up to even the first week of March.
Perfect. That is exactly what we are looking to hear, is that near real-time aspect of this data. But I wanted to open the call just to briefly talk about who Millennium Health is, and for those unfamiliar, just say that we are a company that has over a decade of experience delivering timely, accurate, clinically actionable information through medication monitoring, drug testing services, and pharmacogenetic testing services in all 50 states. And as a leading specialty laboratory, we have this unique capability to provide not only high quality diagnostic testing services, but also to our point, the near real-time data to help clinicians and public health officials better understand emerging trends in their state, in the region of their country, nationally, and even in your own clinic. And I say this because as I walk through some of the data, and again, through some of the data that Eric is going to share with us, we believe we have this ability to provide a novel and unique tool that complements other resources utilized in fighting the overdose epidemic we are currently facing. Now, to better understand just our portfolio of services, I did want to just mention we do offer pharmacogenetic testing. For those that are unfamiliar with that, it is a non-invasive genetic test utilizing an oral swab to identify how a patient's genetics may impact his or her own response to certain medications. And the goal is really to just move beyond the trial and error approach of prescribing to help pinpoint and identify the best medication for a patient. Now, Millennium also offers medication monitoring services, whether that be urine drug testing or oral fluid, and that provides objective information to support improved clinical decision making. We'll focus all of today's presentation will be focused on this service and how it can help improve the clinician-patient relationship. But these services and these tests can certainly be applied together to tailor patient care with what is deemed personalized medication intelligence, and just equipping providers with information that can help with medication selection based on their personalized genetics, and then also monitoring the use of those medications. And the testing process is managed through Intellium by Millennium Health, which is a data intelligence platform that leverages proprietary data intelligence and clinical expertise to help clinicians improve patient care. And now, as I said, we'll be focusing on medication monitoring drug testing services. And I quickly just wanted to show that Millennium does offer one of the broadest testing menus in the industry that includes over 100 parent drugs and metabolites, including not only antidepressants and antipsychotics. And in fact, during the last few years, we've been committed to keeping our testing menu relevant to current trends and expand our testing menu to include things like kratom and fentanyl analogs. And this has allowed us to be the industry leaders of data analysis in this space, and to be able to report and analyze medication monitoring testing trends for many of these substances. And to that point, beyond our product and services, we strive for a best-in-class clinical excellence using our clinical and analytical capabilities to track drug use trends. And this work has led to the development of several publications and trend reports over the years, as well as going back to what Dr. Dawson said, an opportunity to collaborate with federal and state organizations. And our first signals report was released in March 2019. We built on the interest generated by that report with 2 peer-reviewed publications in JAMA Network Open, which help validate our work and support the usefulness of providing near real-time analysis of urine drug testing data to offer more timely information than the traditional data sources. And recognition of our data capabilities led to that opportunity to collaborate with the U.S. Department of Health and Human Services that started in 2020. And we continue that collaboration as of today. And you'll see Eric will speak to some of the very, very latest data on drug use trends later on in the presentation. But in 2020, we released the second version of our signals report and a mid-year special edition report analyzing how drug trends changed during the heightened time of the COVID-19 pandemic. And this work led to a research letter published in JAMA that we co-authored with HHS, which focused on drug trends through September 2020. And it was also during this time, late last summer of 2020, we also began a collaboration with the Ohio Department of Public Safety. And then further, myself, along with Eric and other team members, published in the Journal of Drug and Alcohol Dependence. We focused on drug trends in relation to fentanyl analogs. You then flash forward to January of 2021 with another publication in the Journal of Addiction Medicine analyzing methamphetamine trends, and we'll certainly talk about methamphetamine today. And then I'll bring you to today. Just last week, we released our latest signals report, that being volume number 3, and that's what we'll be reviewing today. And that is a data analysis through December 31st, 2020. And I should mention that we are happy to share links to any of these publications. They're available to anyone. We can post them in the chat, or maybe Sue, you could post them. It looks like Sue, you've already posted them, so thank you so much for that. And we'll certainly make those available. And anyone who's interested, those are available to the public for viewing. You may just need to download it. So anyone who's interested, please feel free to take a look. Now, this brings me to why I think some of this work that we're doing is so important. And as you can see, drug overdose deaths continue to be the leading cause of accidental injury in the United States, surpassing deaths due to suicide, firearms, and even motor vehicle crashes. And according to the CDC, there were over 70,000 drug overdose deaths recorded for 2019, which represented a record high. And if you break that number down into a daily average, that's about 197 deaths per day. The average Boeing 737 can hold about 189 passengers. So the number of drug overdose deaths we're seeing in the nation represents what would be the equivalent of a plane crash per day. And while this is certainly a public health crisis, the substance use epidemic within the context of the COVID-19 pandemic is often lost because of the toll the virus is having on American lives. I'm sure many of you saw that just a week or so ago, we reached over 500,000 deaths for that. But unfortunately, there are early indicators that suggesting that the United States is on track to reach a new record all-time high for overdose deaths in 2020. Over 81,000 drug overdose deaths occurred in the United States in a 12-month period ending in May 2020, the highest number of overdose deaths ever recorded in a 12-month period. And in the midst of the pandemic, what can we as individuals who work in the medical space do to help bring awareness to this issue of substance use and help mitigate drug-related overdoses? And I think it starts certainly with understanding which substances contribute most to drug overdose deaths to better understand where we can focus our resources. And further evidence from the CDC does highlight which specific drugs or drug classes most contribute to drug overdose deaths. And as you can see, deaths associated with prescription opioids, so anyone who may have selected oxycodone as the contributing to over half of the overdose deaths, that maybe early on in the 2000s that was occurring, but we've actually seen recently a decline in prescription opioids causing overdose deaths. And while deaths associated with heroin, the lime green line, were big in 2010, we've also seen recent declines related to heroin overdose deaths. But however, when we look at that third type of opioid on this slide, that being synthetic opioids represented by the orange line, we see a near vertical increase in which the rate at which these are being involved in drug overdose deaths. The synthetic opioid category includes fentanyl primarily, but also fentanyl analogs, which certainly now answers the question that you were asked at the beginning, that fentanyl deaths, that being illicitly manufactured fentanyl and its analogs, contribute to over half of all the drug overdose deaths in 2019. And
with no end in sight, right, Joe? With really no end in sight when you look at the slope of this curve.
Yeah, and you will certainly see that with some of the data that we have as well, that even though this is a different source, in fact, the no end in sight, and we could continue to see even a bigger jump unfortunately, in deaths related to fentanyl, and we'll certainly talk about that. But I should say there's certainly a lot of attention on the opioid crisis, and we're going to talk a lot about that. But I'd be remiss if I didn't just also talk about stimulant-related deaths. And looking at cocaine, the blue line, you can certainly see that there's been a recent surge, but not as dramatically as the rise in deaths associated with methamphetamine, the yellow line. In fact, it surpassed that of cocaine in 2019. And I really love presenting this slide because it gives a real good perspective on the last 20 years of the overdose epidemic that we're facing, and how it's really been driven in different waves, with the first wave of overdose deaths being contributed by prescription opioids, the second wave of overdose deaths being contributed by heroin, and now what we're currently facing, this third wave, being contributed by fentanyl. And some suggest that methamphetamine or some sort of combination with methamphetamine and fentanyl could be the next fourth wave on the horizon. But seeing all this and how those working in the healthcare community to better understand what may be going on in your facility, ultimately medication monitoring or urine drug testing, or even oral fluid testing is a tool often used in clinical practice because it provides objective information to support improved clinical decision making. And It can monitor and support decisions about medication therapy, especially with controlled substances, identify recent use of prescription medications, non-prescribed medications, and even illicit substances, maybe detect medications that may result in drug-drug interactions, advocate for and communicate with patients about individual treatment plan, and certainly identify possible illicit drug, medication abuse, misuse, and diversion. And there are different types of tests out there. And looking more closely, most of you are probably familiar with the presumptive or immunoassay test, which is typically referred to as the in-office based or point of care or EIA analyzer. And probably the best feature of the immunoassay screen is that it can be performed in minutes while the patient is present. But it needs to be mentioned that there are certain inherent limitations in the quality of those results, and understanding that IA tests primarily only detect drug class and cannot distinguish between if there's more than one drug of a class present. So example would be if the patient's prescribed Xanax, but also using Klonopin from another source, the IA test would be unable to determine that both of those were in a patient's system. And another big inherent limitation with IA includes the high cutoff levels and significant rates of error with false negative and false positives that can occur with cross-reactivity. And it should be noted, many of these device manufacturers will put a disclaimer in the product insert and define the results as preliminary, and follow-up laboratory confirmation is recommended. So which brings me to laboratory-based definitive quantitative or confirmation drug testing, which is typically performed using GCMS or LCMS or mass spec technology. And the results are provided generally within 24 hours, but ultimately this type of test can identify all specific medications, metabolites, and illicit substances, which can certainly help more precisely guide clinical decision-making and differential assessment. And because these are quantitative test results, the cutoffs can be set much lower, extending the window of detection while also eliminating error of false positive and false negatives. So just to the reason why I bring this up is it's important to understand these different types of tests, because the data that I'm going to be featuring today all comes from definitive confirmation drug tests from our laboratory at Millennium Health. And I'm just very excited to be able to share and officially go through this report. So we'll start with the first section, which was titled Shifts in Illicit Drug Use Heightened During the COVID-19 Health Crisis. And as we briefly talked about before, the impact of COVID-19 pandemic has had a drastic effect on public health, and the CDC is calling a concerning acceleration of the increase in overdose deaths. And I've already shown you we're on track for a new record high. As Eric mentioned, there's no end in sight. Majority of the deaths are attributed to illicit fentanyl, but we should not forget the recent surge in stimulant-involved overdoses. And in addition to overdose deaths, another indicator of drug use we monitor is drug confiscations by law enforcement. And now the answer to the other poll question, according to most recent reports, methamphetamine is the most frequently confiscated drug by law enforcement, which is interesting given that cannabis or marijuana had dominated that statistic for the last few decades. And to Eric's point again, I don't see an end in sight for the proliferation of fentanyl and even methamphetamine. Changes in production and pricing have been the main driver, I think, and why we're seeing such drastic numbers that we've gone through. Knowing that fentanyl is entirely synthetic, meaning it's fully man-made in a laboratory, unlike heroin, which really needs good weather to be grown and then produced. Fentanyl can be just made in a laboratory, and I think probably the profitability of fentanyl is the big driver, and just absolutely staggering. The DEA there's a source that says 1 kilogram of heroin may result in a revenue of about $80,000 once it's sold on the street, but the potential profit of that same kilogram of fentanyl can approach nearly $2 million. Just absolutely staggering numbers. And clearly, if you're in the heroin business, you're probably thinking that you need to switch over to fentanyl, which is why we're seeing such a big change over in individuals who are dying from fentanyl. And other changes.
And to add to that, Joe, if I may,
yes,
appreciating those revenues is crucially important to not just understanding, why drug trafficking organizations have such interest in fentanyl, but also why we'll see in this report we see growth in areas where fentanyl already existed. Right, the drug trafficking organization is attempting to oversupply current markets with fentanyl. Right, they want access to fentanyl to everyone. But what we also see, and Joe will point out, significant growth in new markets. When you're talking about driving profits of $2 million off something that cost you $5,000, obviously there's tremendous motive to go seek out new markets, and we see that in the fentanyl trends.
Yep.
We even see some of that with methamphetamine as well. Quite honestly, as Joe will point out, but with fentanyl, it's striking.
Yeah, and to your point, we've seen some big changes with methamphetamine, and production of methamphetamine has evolved from the more traditional ephedrine-based synthesis to now they use this more lesser-known precursor chemical called P2P or phenyltropropamone, and it's really just led to changes in purity and price. In 2007, average methamphetamine purity was around 50% and sold for about $150 per gram. But a decade later, we now know methamphetamine is the #1 seized illicit substance. Purity has reached nearly 96% and costing only $56 per gram. And given these changes, this is likely the reason why we're seeing methamphetamine as the #1 seized illicit substance. And because fentanyl, cocaine, heroin, and methamphetamine are not only very common, but also potentially deadly, our team has been following these trends for the last for the last few years on these 4 drugs very closely. And as I alluded to in the presentation, the purpose of this first section of the signals report was to extend the timeline of our publication that we did with the HHS and provide additional data through the end of 2020 and to see whether those trends continue as the pandemic wore on. So the methods were that we did a retrospective analysis looking at 3.5 million de-identified urine drug test results collected between January 1st, 2013 and December 31st, 2020. The analysis included urine drug test positivity rates for fentanyl, methamphetamine, cocaine, and heroin. Patients with reported prescriptions of any of these drugs, like fentanyl, were excluded in order for us to just truly focus on illicit use. And in addition to looking at the yearly positivity rates between 2013 and 2020, we then also compared the 2 time periods before and after COVID-19 was declared a national emergency on March 13th, 2020. So here is the first figure of section 1, which shows national positivity rates for each of the 4 drugs between 2013 and 2020. And interestingly, as you can see, positivity during COVID-19 for methamphetamine and fentanyl, represented by the blue and orange lines respectively, have mostly stayed above pre-COVID levels, particularly when we look at fentanyl. Here's the dotted line for when the national emergency was declared on March 13th. And positivity rates had been steadily increasing, but you can just see, even for all of the drugs, that the 4 drugs that we looked at, we saw initially significant increases in positivity. But after initially increasing, cocaine, represented by the yellow line, and heroin, represented by the black line, those appear to have fallen back down to pre-COVID levels. But methamphetamine and fentanyl both have seen their positivity increase and stay relatively high, especially with fentanyl. And
yeah, and just to that point, Joe, if you'll go back 1 slide.
Yeah.
We were hopeful. If you look at the methamphetamine curve, we were hopeful as we approached December. You start seeing a little dip in positivity, right? If you look at the tail end of that blue curve, right, exactly right there, it's starting to come down, and we were hopeful we would see that trend continue. But as we continue to analyze that data and report our findings to HHS, as I mentioned at the outset of the discussion, we have in fact seen that the methamphetamine is bumped back up slightly and has remained flat since. So it is remaining significantly elevated, as is fentanyl, which are, for all the reasons you stated earlier, quite concerning.
Yeah. And when we break it down just from a regional perspective, this getting back to your point, Eric, and we'll get an even better understanding on the next slide, but just focusing on rates during the COVID-19 time period, which was March 13th through March 13th, 2020, or March 2020 through December 2020. The heat map is really a helpful way of showing where urine drug test positivity rates across all 9 different census divisions within the US. And darker shade of red represented the higher positivity rates. And as you can see, fentanyl and cocaine remain more common in the eastern parts of the country, while methamphetamine, more traditionally, as we kind of come to know, that methamphetamine and heroin are predominantly higher in the west and the west of the Mississippi River. But taking a look at the positivity rate changes between pre-COVID and COVID time periods, what you're going to see is going back to what Eric said. And just to orient you to how the table's laid out, the national rate changes are on the bottom row here. And knowing that drug use trends often differ by region, we also include the breakdown of the 9 different census divisions. And if there's a star next to the number and confidence interval, this would indicate that the finding was statistically significant. And rate increases are shaded in red, while rate decreases are shaded in green. Now, looking at the bottom row, we see that nationally, the increase in fentanyl and methamphetamine positivity were statistically significant, increasing 78% for fentanyl and 29% for methamphetamine when comparing the 2 time periods, whereas changes in heroin and cocaine were not significant. Now, looking at the results by census division, each division had a significant increase in positivity for at least 1 drug. Notably, the East, North, Central, and Mountain divisions had significant increases for 3 of the 4 drugs. And it's also important to recognize that fentanyl increased in all US Census divisions, but it was led by the Pacific and Mountain divisions. And as the heat map on the last slide showed, while fentanyl positivity has traditionally been highest in the eastern parts of the US, the remarkable increase in fentanyl positivity in these Western divisions is important to be aware of and coincides with the large increases in illicit fentanyl-related deaths for the West that were recently reported by the CDC. And equally as important is focusing on methamphetamine, we see greatest increases in the New England and Mid-Atlantic divisions, which is again consistent with community level reporting, suggesting that while methamphetamine has traditionally been more widely available through the West and Midwest, drug traffickers, to Eric's point, are seeking to establish new customer bases in non-traditional markets, including the Northeast.
Yeah, if I just may add to that, I can actually give you, let me just provide a couple of specific numbers just to give you a sense of this. So, and I'm looking at what we report actually to HHS. So in terms of non-prescribed fentanyl positivity, the state of Illinois actually leads the nation currently at over 30%. It was 31.4% in our most recent report. Kentucky follows at number 2 of almost 28%. It was 27.9. So, the point I continue to make is where fentanyl has been, it continues to grow, but not at the rate that it's now growing in places that it wasn't prior. When we look at Arizona, we've seen significant growth. It currently ranks 3rd in the nation at almost 24%. The states further out west along the Pacific coast, they don't have nearly the positivity as the states I just mentioned, but they are in fact seeing the greatest growth. The Washington, Oregon, California, these states are all still in single digits in terms of fentanyl positivity, but growing significantly. And so we continue to watch those states very carefully, as Joe will point out here. They're all listed under fentanyl. Methamphetamine is very much a different story. It's the reverse. It's been historically west of the Mississippi. We see that in our positivity rates. The highest is in Iowa at over 32%. Those kind of Midwestern states, but we're seeing significant growth out east, especially in the Northeast, as you can see on the slide here.
Yeah, and to your point, this data is really only through just looking at the percent change pre and during COVID. And you can see that the states under fentanyl, many of them are in the western parts of the United States. 4 out of the 5 Pacific states, Washington, Oregon, and Alaska and California, more than doubled their fentanyl positivity during COVID. And to your point, Arizona is both for methamphetamine and fentanyl. But Eric, what I like about you sharing your data is that the trend seems to be continuing. Again, this data only through the end of 2020, and what you're sharing is through March of 2021. So
right.
very interesting there. And as you'll see, there were no statistically significant changes noted for cocaine, which is why it is not listed here. Now,
yeah, and I think it's important, Joe, if I may, just to speak to the significance. You go to the next slide.
sure.
I know we have to watch our time. I could speak to this all afternoon. You know, these are tough numbers to review. You know, this is not a good situation. But there's some incredibly important things to be gleaned from these numbers, and that is if you're out west practicing, right, reminding those patients that fentanyl is present and growing, telling everyone what that means in terms of risk of overdose and other consequences, and likewise out east, recognizing the challenges that come with not just with really any fentanyl use, but acute intoxication as well as stimulant use disorder, right? Unlike the opioids, there is no naloxone for acute overdose with methamphetamine, and there's no buprenorphine to help you manage someone with a stimulant use disorder. So, you know, for clinicians in the Northeast and out east, recognizing the challenges and beginning to make sure that they're abreast of how best to care for these individuals, whether it's acute intoxication or those with chronic use. I mean, this is a tough situation on both ends of the country, but for different reasons.
Yeah, and you can speak to, we know that there's continued research and strategies specifically for methamphetamine, but of course with fentanyl as well, hopefully to help improve the treatment and prevention efforts needed to help these unfortunate health outcomes and health consequences. But it's interesting because we've reported on it is basically bad news at this point, but I'm excited to at least share this section because I think we can take some solace in the data that we have here in the collapse of carfentanil. And I should have mentioned this earlier, but fentanyl how powerful and potent fentanyl is. It's estimated to be about 50 to 100 times more potent than morphine. And I think its potency is a large part of why illicit fentanyl and its analogs continue to contribute to over half of the overdose deaths. And as I said, fentanyl is created in a lab. It can be chemically modified, and it's created many fentanyl analogs that are structurally similar to fentanyl, but you can slightly alter, and when you alter the chemical properties, it can range in potency. And so, for example, acrylfentanyl has a potency similar to fentanyl, while carfentanil, which many of you have heard of, maybe because it's being featured in the news, it has a potency that is up to 10,000 times more potent than morphine and 100 times more potent than fentanyl. And acrylfentanyl is actually a Schedule I drug. Carfentanil is a Schedule II, not approved for use in humans. So carfentanil has been used as a tranquilizing agent by veterinarians in zoos and other large wildlife environments like elephants and large mammals. And this visual here actually just shows you the amounts of heroin and fentanyl and carfentanil that could cause an overdose, to help demonstrate how just a few granules of fentanyl or carfentanil can be enough to cause an overdose. And Eric, I've heard you talk about it in terms of just grains of sand, just losing just 2 or 3 grains of sand comparable for carfentanil is enough to cause an overdose. And we've actually published on fentanyl analogs in the Drug and Alcohol Dependence in the fall of 2020, and we wanted to update that research. We found in that previous study that the top 10 counties for carfentanil were located in the northeastern parts of Ohio, suggesting that it's geographically limited. However, the second most commonly identified analog not associated with fentanyl metabolism or synthesis was acrylfentanyl, and therefore we focused our analysis in section 2 on fentanyl, carfentanil, and acrylfentanyl. And for this section, we looked at 250,000 de-identified urine drug test results from January 15th, 2019 and December 31st, 2020. And specimens positive for fentanyl or its metabolite underwent additional testing for fentanyl analog, carfentanil and acrylfentanyl. And any patient who had a reported prescription of fentanyl was excluded from the analysis. So we have some good news here, and what we found is in stark contrast to the increasing fentanyl positivity. Thankfully, As you can see, carfentanil, represented by the orange line, dropped sharply after the COVID-19 declaration, decreasing from approximately 3.7% nationally to about 0.3% after this date. And carfentanil's near disappearance leaves acrylfentanyl as the, well, this is not good. Eric, I may be getting rebooted. Pardon me 1 second, everyone. I don't know why I'm getting this.
It's all right. Yeah, it looks like it's going to reboot in about 5 minutes or so, there, about 4 minutes and change.
Yeah.
So if you want to go ahead and do what I'm gonna, if you want to go ahead and do that, there's a question that's come through from the panel, and it's: do you ever see fentanyl production to be stopped since it's such a huge problem? This is by Courtney. So while you handle the technical thing, if you want to answer that question.
Yeah, I think there's been some reports that there were illicit manufacturers, I should say, clandestine labs in parts of the Wuhan, China district that were manufacturing fentanyl. And because of the COVID-19 pandemic beginning in 2020, there was a stop to that. And that's possible that we did see a slight decline in maybe trafficking. And I know that carfentanil, and Eric, you can speak to this as well, is that carfentanil, with its dip in positivity and it not being found by different U.S. government agencies looking at seizure data, and even other data that we've seen out of Ohio, that they've also seen declines in trafficking of carfentanil. It's possible that because of COVID, that and the closing of borders and the like are the reasons why we're seeing potential decreases in that. But Eric, maybe you can speak more to that.
Yeah, I think it's given the profit that is associated with the sale of fentanyl, I'm just not confident we will see that drop. I would love to believe that it's possible with interdiction efforts, and I know that's one of the reasons HHS has such interest in our information. But gosh, I mean, when you're talking about deriving $2 million, and even some of the most recent data that I've seen actually suggest prices are up. The trafficking organizations are using COVID to push prices even higher. So that revenue may even be more than $2 million per kilo. I'm just not confident that we're going to see any change soon. But we'll see. But it's terrifying to me as a critical care pharmacist, knowing how fentanyl is used in a hospital, in a surgical setting primarily, and where the patient is surrounded by support staff, to think that drug is out in our communities and growing by leaps and bounds everywhere is terrifying.
All right, gentlemen, I've got Sue went ahead and put the presentation up in the slides. So if you just direct us in terms of moving forward or backwards, and we'll go ahead and follow along your lead. And then, but we'll keep the presentation going if that's okay with you guys.
Well, I am unfortunately going to get rebooted in 1 minute and 35 seconds. The countdown is on.
I'm happy to walk through the slides if you'll just allow me the opportunity to share my screen. I have the presentation.
And I will restart. I'm going to restart right now and see if I can get back in. Okay. I'm so sorry about that.
No worries.
So that takes us to section 3. I trust everyone can see section 3, an evaluation of pain medication misuse in the midst of the pandemic. So this was a new area of exploration for us. Most of the work that Joe had pointed to that we had done was focused on the kind of big 4 illicits. We'd done some work with Gabapentin, kratom, and some other things, but we had not focused on the prescription opioids. But we had a lot of interest in them as it relates to COVID, simply because we know some changes that occurred in terms of allowing physicians to prescribe these medications during COVID, right? Obviously, and Joe pointed to this, there's been intense interest on reducing the number of prescription opioid overdoses in the last number of years. The rescheduling of hydrocodone as a Schedule II medication was one of those efforts. We've also watched tramadol very closely. And we've seen an uptick in the number of tramadol confiscations really since the rescheduling of hydrocodone. But with COVID and the demand to be more socially distant, there were allowances made where physicians could prescribe these medications, hydrocodone, these other Schedule IIs, without an in-person visit. So we had a lot of interest in analyzing non-prescribed use of, specifically, we looked, as you can see here, at gabapentin, oxycodone, hydrocodone, and tramadol, but our primary interest was in oxycodone and hydrocodone. And all of the methods were the same as the first section. It was 3.5 million patient samples evaluated over the same time frame. Here is the declaration represented by the vertical line, but here is the trend line for non-prescribed use of hydrocodone and oxycodone. And you can see, unlike certainly what we saw in section 1, hydrocodone and oxycodone use seem to be really indifferent to the presence of COVID. It simply made, there's no difference in any of these curves. That's slightly different than gabapentin. You can see with gabapentin more mirrors like heroin and cocaine. With the declaration of COVID, we saw an initial uptick in non-prescribed gabapentin use, but it's since fallen. And tramadol did climb following the declaration and has remained up. Now, nothing as significant as like fentanyl and methamphetamine. In fact, the significant increases that we see with tramadol are restricted to just very few locales, primarily in Tennessee, Ohio, and Kentucky. So I certainly don't want you to look at this information that I'm sharing with tramadol and let that set off any number of alarm bells. I don't feel that way about tramadol. It is certainly worth watching, and we will continue to watch it. But at this point, it seems to be very limited to these areas, and even there, the increases are nothing like fentanyl and methamphetamine. Gabapentin, as I said, has remained relatively steady. It initially increased and then fell back, and we were happy to see that there was no increase for hydrocodone and oxycodone. And then we move to the last section, section 4, entitled Methadone Maintenance, Unexpected Findings Raise Risk. Much like our interest in hydrocodone and oxycodone, the prescription pain medications, we had a great interest in what was happening with methadone during COVID, because again, there were allowances made, as you can see here. State and federal agencies eased restrictions on take-home methadone for stable patients during the pandemic, right? So it was a much different process to taking to your methadone than what was happening by and large prior to COVID, right? Whereas the picture described, you came to the clinic every day and received your medication. So we have watched this patient population very closely as well. And you can see during 2020, what you're looking at is all of these individuals are prescribed methadone. The blue bars represent positivity for the different analytes here, the different drugs here that we analyzed. You're looking at positivity for those that were not taking their methadone. So we tested them for methadone. The methadone was not present, but you can see the positivity rates for the different drugs that were present. We compared that to positivity rates in those that were prescribed methadone, but actually taking their methadone. They're represented by the orange bars. And you can see for, I think, all but gabapentin, and I think it was marijuana was the other one. No, marijuana was significant, I'm sorry. And this is really to be expected, those not taking their methadone had much higher drug use than those taking their methadone. But I say that, though recognizing the size of these orange bars, we were alarmed by the amount of drug use that still is taking place in those that are prescribed methadone and taking it. And in fact, as it says here, over 90% of those not taking their prescribed methadone had 2 or at least 2 substances found. But look at the number for those still taking their methadone. In over 50% of those patients, we still found 2 or more medications. And here is the top 10 list of what we did find. Fentanyl alone is the most common finding in this population. And we've seen this now in a number of analyses that we've done. You know, we typically think of fentanyl being found with something, being spiked into heroin, being found with cocaine, methamphetamine, etc. But actually, fentanyl alone is the most common finding. But you can see fentanyl with something else made up, 7 of the top 10. So fentanyl is the star of the show and remains so for all the reasons we have described. You can see, a number of different combinations found commonly in this population. And we already have planned a much deeper dive into this population that we'll be pursuing as a peer-reviewed publication. So with that, I'll close with this slide. During COVID, fentanyl and methamphetamine increased significantly, as did tramadol, but tramadol was limited to just very few locales. Thankfully, carfentanil dropped sharply. I say thankfully, recognizing, however, that in total overdoses are up. So it's not necessarily something to jump for joy about that carfentanil dropped, given the fact that overdoses are up in total. But I think it is fair to imagine what might they have been if carfentanil was where it was a couple of years ago as well. But we still do see carfentanil in a few places: Ohio, New York, and Florida primarily, but not common by any means. As I've already stated, hydrocodone, oxycodone, and gabapentin remained essentially unchanged. The methadone population really continues to worry us, and I think the take-home message there is the social distancing, the physical distancing demands that have taken place with COVID has created obviously stress on all of us, but for the population with SUD, that kind of aloneness, that distancing is it creates incredible anxiety and stress. And I just think it's just so important that we get everybody vaccinated so we can connect these individuals back with their support systems, with the clinicians that are caring for them, with other support groups, whether that be 12-step programs, etc. They have to feel connected with their support. It's such a big piece of treatment. Substance use trends, as you kind of always have, will likely continue to evolve. We'll follow fentanyl very closely and continue to report on these things. So with that, I'll stop. We'll open it up to questions. I guess there perhaps are a number in the chat. I'm not sure of the time we have left. If we have time for a single question, and I'm happy to answer those, or I'm more than happy to provide you with my email address, and you can feel free to reach me after.
Dr. Stanton and Dr. Dawson, I guess one of the questions I have, we talked about fentanyl being such a huge problem, and you talked about the need for people to get vaccinated and get people kind of back into the social and away from the isolation. Do you see for the treatment centers out there, do you forecast that they may see a rise in folks going to get treatment once in this post-COVID, let's say by summer, if everyone's vaccinated?
Right. I think that is right. In fact, I've had that discussion with a few physicians that they expect that well, and it's not just related to fentanyl. I think the other thing that we have to keep a close eye on is alcohol use. In fact, we have in about 30 minutes, I have a meeting on a publication that is in final review that's looking at alcohol use. We've seen an uptick in alcohol use as it relates to during COVID. And so I think that's another population. I mean, we all know what was happening. I saw it here, that you had lines wrapped around the liquor store, and people were stuck at home. They start drinking, and now as we return more and more so to our lives pre-COVID, there will simply be the case that some of those individuals find it tough to stop drinking. And so I expect to see simply an uptick in those diagnosed with SUD for any number of substances. I think alcohol and these other things because of just the incredible stress that we have all felt during this time. And so combined with access to these things. So we'll see, but I think you're right.
Yeah.
Well,
I hope it's the case, quite honestly, that they find access to care.
Well, I want to thank both Dr. Dawson and Dr. Stanton for your participation. We are running to the end of our time here, so definitely appreciate your participation and sharing this incredibly valuable information. And we'll be sharing this for with the common questions. We'll be sharing these slides and to the audiences afterwards. Folks who may have missed it, we'll be sharing that. So again, I thank you both so much, and we appreciate your help.
Thank you. Have a great rest of the
have a good one. Yeah. Take care.
Thank you.